I want to talk today about a topic that is dear to me, which is how to assess JVP by exam, but also nowadays by point-of-care ultrasound. And I will also talk a little bit about lung ultrasound, which is a skill that we need to acquire. You can save more lives by doing proper physical exam, especially proper JVP exam, than by doing complex stenting a lot of time. Elevated JVP at rest or with hepatojugular reflux is the most important congestive sign in decompensated heart failure. It's the most sensitive and specific findings. In some studies, over 80% sensitivity and specificity for the diagnosis of elevated right, but also left-sided filling pressures. In fact, JVP and wedge pressure are proportional and concordant in approximately 80% of heart failure. Remember that concordance, 80% between wedge pressure and JVP. This means that most left heart failure is associated with some right heart failure, hence the elevated JVP, but also most right heart failure is secondary to an active left heart failure. About 20 to 30% of decompensated left heart failure may have normal JVP, meaning they may have left heart failure without right heart failure. They will have high wedge pressure with normal right atrial pressure. Their RV is still well compensated, hence their right atrial pressure has not risen yet. But in the majority of the cases, there is concordance between JVP and wedge pressure, and JVP is an important congestion target for diagnosis and treatment. And these are the references that indicate those numbers, and here I summarize the sensitivity and specificity of JVP for predicting wedge pressure based on those various studies, and you can see those numbers here. Now, how to assess JVP? The jugular vein acts as a manometer for the right atrial pressure. The higher that right atrial pressure, the higher the pulsations will be seen above the right atrium. The jugular venous pressure is assessed by analyzing the height of the jugular venous pulsations, A and V pulsations, in relation to the angle of Lewis, the sternal angle, which is around 5 centimeters above the right atrium. The right or the left side of the neck may be analyzed. The analysis starts at about 45 degrees patient position. Then the position of the patient is adjusted according to the visualization of the pulsations, as I will explain. Typically, we seek the internal jugular pulsations. We don't see the internal jugular vein. We only see the reflection of those pulsations through the neck skin. So we seek the A and V wave of the internal jugular veins. Those look like flickers, like vibration, oscillation over the neck. The internal jugular vein itself is not visible. So you look for pulsations on a non-visible vein. Sometimes those pulsations may be analyzed over the external jugular vein in case that external jugular vein is distended. This will be the minority of the cases, and those will be cases where you analyze the JVP over the distended external jugular vein, or you analyze the JVP over a JVD. But in the majority of the cases, you will have elevated JVP without JVD. So that's why when a student tells me the patient does not have JVD, okay, I'll tell him it doesn't mean anything. What is the JVP? Now, the highest point of those visualized pulsations, typically on the internal jugular vein or occasionally on the distended external jugular, the highest point is what we call the JVP. And the JVP is the vertical distance to the angle of Lewis plus the 5 centimeters between the angle of Lewis and the right atrium. When the sum is 9 centimeters or more, then we have elevated JVP, meaning when the JVP is 4 centimeters or more above the angle of Lewis, the JVP is elevated. The analysis starts at a 45-degree patient position. Now you can imagine in a patient with a JVP of 3 centimeter, right atrial pressure of 3 centimeter, in this position, the pulsations will be here. They will be below the bottom of the neck. Therefore, they will not be visualized. So in order to visualize the pulsation when you don't see them in this position, you need to drop the patient furthermore, make that jugular vein more in line and closer to the plane of the right atrium so you can see that JVP. So that's why I said you start 45 degree, but you adjust the angle. If someone's RA pressure is 0, you will only see the JVP pulsation when he's flat. In patients with severe JVP elevation over 15 centimeters or so, the pulsations may be at the level of the earlobes in this position. So the patient may need to be further elevated, made further upright in order to see the upper JVP point. There is this classic JVP pulsations at the earlobe that we see in patients with severe heart failure. So we should seek those JVP pulsations at the earlobe. You will see that earlobe vibrating in those. And this slide puts in text what I just explained if you would like to read it. Another idea here, if somebody is sitting upright at 90 degrees and you see JVP at the bottom of his neck, that means that JVP is already elevated. In normal people, if he's sitting at a 90-degree angle, you shouldn't see the JVP even at the bottom of the neck. So if you see it at the bottom of the neck, considering the distance between the bottom of the neck and the angle of Lewis in an upright position, you're already 9 centimeters or more above the right atrium. Now, very importantly, as I mentioned, JVD, jugular venous distension, is different from JVP. Jugular venous distension is distension of the external jugular vein, and when you see it in an upright position, it signifies elevated JVP. However, JVD is very insensitive, meaning you can have somebody with florid right heart failure and massive TR and massive JVP, yet no JVD. So the presence of JVD in an upright position between 60 and 90 degrees indicates right heart failure. The lack of JVD means absolutely nothing. And actually, in most elevated right atrial pressure, there is no JVD. So when a student tells me the patient has no JVD, it means absolutely nothing. You should seek the JVP. It's a very important skill. And again, that JVP is often a reflection of the waves, oscillations of the internal jugular vein that you do not see. This is an illustration of what the JVP waves represents. You have A wave, which corresponds to the atrial contraction. You have the X descent, which corresponds to the atrial relaxation in the first portion, then to the downward pulling of the tricuspid valve during ventricular systole. Those two portions are interrupted by the C bump of isovolemic ventricular contraction. Then you have the V wave, which represents the atrial filling during ventricular systole, and it peaks at the very end of ventricular systole, unlike the arterial and the ventricular waveform, which peak throughout ventricular systole in a plateau fashion. Then you have, after V wave, the Y descent, which occurs in early diastole as the tricuspid valve opens and briskly empties in the ventricle. This is an illustration of right heart failure with elevated right atrial pressure. Note how the Y descent becomes more pronounced with inspiration. As the RA fills more with the inspiration, the V has a propensity to rise, and especially the Y descent has a propensity to fall as the non-compliant RA empties. You also have another sign with RV failure, which is that Kussmaul sign, wherein the RA pressure does not drop in inspiration. Only the Y descent becomes deeper, but the RA pressure mean remains the same and may actually rise along with a rise in the V wave. And this is a recording of a special type of RV failure. It's RV failure with severe tricuspid regurgitation, where the RA waveform becomes ventricularized, it peaks in a plateaued fashion similarly to the ventricle and to the arteries. In this case, the severe TR eliminates the second portion of the X descent and lifts the C wave up and makes it fused in one plateau with the V wave. It's a pathognomonic of severe TR, ventricularized RA pressure. You can see it on a JVP exam, as I will show. This is another illustration of a ventricularized RA pressure. It peaks in a plateaued fashion throughout all of systole, like an artery, like a carotid pulse. This is another ventricularized RA pressure, plateaued throughout systole. Another note, deep Y descent and Kussmaul sign are traditionally associated with constrictive pericarditis, but they are in fact far more commonly a sign of RV failure than constrictive pericarditis. One additional note, the only condition where you have high right atrial pressure with a flat Y descent is tamponade. FYT, flat Y tamponade. In tamponade, you have high right atrial pressure with deep X descent and a flattened Y. Now, when you see pulsations or flickers in the neck, the most difficult step is to distinguish those JVP pulsations from the carotid pulse. And how do you do that? Here are some tips I will give you. One, the morphology. The JVP is an undulant waveform with the flickers. It's like a shallow undulation, vibration, flickering. You have two upright flicker AV and two downward flicker XY per each cardiac cycle, whereas the carotid pulse has one very prominent pulsation in each cardiac cycle. And frequently, in my experience, the most obvious waves are those downward flickers, X and Y in inspiration. I often see those dips, those two dips down in inspiration. The exception to that morphology are severe TR and severe right heart failure, and sometimes atrial fibrillation, where you lose the A wave and you have a dominant V wave that mimics the pulse. This is what we call ventricularized right atrial pressure or ventricularized JVP that looks like a pulse. And it's particularly the case in severe TR. We call it CV wave, as you might have seen in my hemodynamic lecture. In AFib, JVP may have only one wave, V wave, but actually you frequently have prominent C wave in AFib. So you actually do have CV waves in AFib. So you still have typically two upward and two downward flickers in AFib, unless you also have severe TR with it. So that's the first tip. It's the morphology and especially those two downward and two upward flickers, mostly visible in inspiration. And you can do deep inspiration to make those especially downward flickers X and Y more pronounced and more visible. Third tip is the JVP level on the skin varies with patient position. So if you see JVP pulsation here, but you're not sure, is this JVP or is this carotid pulse, move the patient up. If you see that that pulsation moves down on the patient's skin as you move the patient up, well, this is likely a venous pulsation. The carotid pulsation would not change in level with the change in patient position. But what I find most helpful is deep inspiration and this number 4, hepatic pressure. So you do hepatic pressure, right upper quadrant pressure for 10 to 20 seconds while the patient is breathing normally. Hepatic pressure may help the JVP pulsations become more pronounced and may help them stand out over the carotid pulse. It will make those JVP pulsations more visible and more pronounced in most patients, even those with normal JVP. So even if your filling pressures are normal, JVP is normal and your JVP does not rise with hepatojugular pressure, yet the JVP waves will become more pronounced and more visible with hepatojugular pressure, and that will confirm to you that what you're seeing is a JVP. Now, something else may happen with hepatojugular pressure. When you do that hepatic pressure for 10 to 20 seconds, while the patient is breathing normally, that JVP may rise 3 centimeter, and that will be called positive hepatojugular reflux, which will be a reflection of, one, that what you're seeing is indeed a JVP and it's rising with pressure, not just it's becoming more pronounced, it's actually rising in level. And two, it's abnormal because it is rising with hepatojugular pressure. This is what we call positive hepatojugular reflux. A positive result is defined as a sustained rise of JVP of more than 3 centimeters following more than 10 seconds of pressure on the right upper quadrant during normal breathing, no Valsalva, or a fall of JVP upon release of that hepatojugular pressure, a fall of 4 centimeters or more. You don't want Valsalva because inherently Valsalva will raise your JVP. That doesn't correlate with a true abnormal elevation of JVP or with heart failure. I will show you here some patients' images to illustrate how to distinguish JVP from carotid pulse. This is a patient with dyspnea. The carotid pulse is indicated by the red arrow, the JVP is indicated by the blue arrow. So you can see here the carotid pulse. It's a strong single pounding per cardiac cycle, whereas look here for the JVP, it's subtle. But you can see the flickers, especially in inspiration, the two downward flickers in this area. You see, look again, two downward flickers in this area, whereas single strong pulsation in this area. Two downward flickers. Usually in that semi-upright position, when the JVP is normal, most often I see it around here. When the JVP is very elevated, most often I see it around here. It makes that earlobe oscillate. So this patient has a normal JVP. This is another patient with dyspnea, and you can see she's having accessory muscle use. And look at the jugular venous pulsation. It's very obvious here. You see those nice two dips, those flickers, undulations. Two dips down, two dips up. But seek it along the whole length of the neck. Seek the highest point. This is not the highest JVP point. This is the highest JVP point. Watch here. You see it here as well. You see that flickering here, the second arrow. You see it here. This is the highest point. See those dips, especially in inspiration, the two downward dips. On the other hand, you can see the carotid pulsation here. It's a single strike per cardiac cycle. Watch it here. Versus that flickering for the JVP. The most subtle is here, but that's the most important point because this is what the JVP height is. This is another case. You can see strong single pulsations here close to the earlobe. Those look like carotid pulsation. But I can tell you this is actually a ventricularized jugular venous pressure in a patient with atrial fibrillation and severe tricuspid regurgitation. Now, the way I can tell this is a JVP, not carotid pulse, one, this patient has a severe JVD in an upright position, so I know he has an elevated JVP, which makes me suspect that this is potentially the JVP. Number two, in a patient with JVD, you can try to seek those pulsations on the distended jugular vein itself, in which case, even if the pulsations are ventricularized and they look like a carotid pulse, if they are seen on the vein itself, then those are venous pulsations. So that's the number two. I don't quite see the JVP over that JVD itself in that external jugular vein. So this was not very helpful here. Number three, you can do maneuvers. Do abdominal compression and see that that pulsation becomes even more pronounced outward. You can do deep inspiration. Deep inspiration, somebody with severe right heart failure, it will make the Y descent more pronounced, and it will make the V wave more pronounced. It may become more pronounced and become even higher. It makes that earlobe bounce more. This is what we call the Kussmaul sign, which people associate with constrictive pericarditis, but it's much more commonly seen actually in right heart failure. So deep inspiration or hepatic pressure will make this more pronounced and even higher. And that will confirm to you that what you're seeing, even though it looks arterialized, it's actually JVP in somebody with AFib and severe TR. And this is another case of ventricularized JVP. Again, you see a single pulsation in the neck that could look like carotid pulse. However, here it's easier than the prior case because that single pulsation is seen in the vein, in the external jugular vein. So you have a JVD of that external jugular vein. And in that JVD, you have a ventricularized JVP of over 15 centimeter. This is pathognomonic for severe tricuspid regurgitation, which this patient had. She had severe TR, severe right heart failure, and in fact, she has distended superficial vein of the chest and the upper extremity as a reflection of that high venous pressure. Now I will move on to describe how to get JVP by ultrasound, which we should be doing more routinely. Nowadays, ultrasound is a new stethoscope, and we should all be having during our rounds a point of care ultrasound, and we will assess more accurately the JVP and less subjectively via ultrasound, and it's very easy. So what you do, you scan the neck in a transverse view from the bottom of the neck upward, and you localize the IJ versus the carotid artery. So you start like with a JVP exam with a patient in a semi-upright position, and you scan the internal jugular vein in a transverse view from the bottom of the neck upward, and you distinguish the internal jugular from the carotid artery, and you seek the point where that IJ spontaneously collapses. The point where that internal jugular is nearly collapsed throughout the respiratory cycle corresponds to the JVP point. So the point of near collapse of the internal jugular is your JVP. And one landmark annals paper used more specifically this description. The point where the IJ is consistently smaller than the carotid artery throughout the respiratory cycle is the JVP point. I prefer to use the near collapse of the IJ throughout the respiratory cycle. After you find that point of near collapse, you may also confirm that point by using a longitudinal view. The longitudinal view will show you a point of transition from open vein to near collapse. You will have this wine bottle appearance. That point of transition is the JVP point. Now, as it is with the JVP exam, the patient position may need to be adjusted. If at 45 degrees, the jugular vein is already nearly collapsed at the bottom of the neck and consistently smaller than the carotid at the bottom of the neck, that means the JVP is likely low. You need to put the patient further down and find the point of collapse of that IJ. If, on the other hand, the internal jugular vein does not spontaneously collapse at any neck height, the JVP is high, and the patient may be positioned further upright to find the higher level of jugular collapse. An idea derived from that, if you have an upright patient at 90 degrees, if the IJ is larger than the carotid at the bottom of the neck in the sitting patient, inherently your JVP is already high because your JVP is already over 9 centimeters above the right atrial. The similar concept applies to physical exam. If the JVP is seen at the bottom of the neck in an upright patient, your JVP is already 9 centimeters or more. It's already 4 centimeters above the angle of Lewis. Now, some important tips for ultrasound. It's important to distinguish the carotid artery from the jugular vein, which is a lot easier by ultrasound than by exam. You can collapse the vein with probe pressure, except rarely in severe heart failure, but the hint in that case would be that the vein would be much larger than the carotid, and in that case, the larger structure is actually the vein. So that's how you can identify the vein when it cannot be collapsed. The larger structure would be the vein. The second idea is that the vein size varies greatly with respiration, except in severe right heart failure where you get less respiratory variation. The vein size varies with position. The vein size varies with Valsalva. So you ask the patient to do Valsalva, it will bulge up. And the vein size will vary with hepatojugular compression. Whereas the artery does not collapse with probe pressure and has a prominent pulsation. Also, the jugular vein is more lateral than the carotid artery overwhelmingly. There are 3% of the cases where the IJ is more medial than the carotid, but over 95% of the time, it's more lateral. So those are 6 tips that help you distinguish the jugular vein from the carotid, and oftentimes it's easy. And the vein is usually larger than the carotid until the JVP point. Before the JVP point, the vein is larger than the carotid. Other notes here: for JVP measurement, seek the point of spontaneous jugular venous collapse. You collapse the vein with your probe to prove it's the vein, but you're seeking spontaneous jugular venous collapse to call the JVP point, not the collapse with the probe pressure. Another interesting note: whether with exam or with ultrasound, whenever you see episodic robust pounding neck pulsation, not with every cardiac cycle, those may constitute large Canon A waves and are seen with AV dissociation, such as during PVCs and in complete AV blocks. This is a nice paper in Annals of Internal Medicine that validated ultrasonographic JVP assessment, and it showed that it correlated with invasive right atrial pressure with a high sensitivity and specificity and an area under the curve of 0.84. And in that paper, they defined the JVP point as the point where the IJ is consistently smaller than the carotid artery throughout the respiratory cycle. I'm going to give you a case application here. You have a 76-year-old man with a history of heart failure with PSRVF. He's presenting with severe dyspnea, no crackles on exam, no peripheral edema, systolic blood pressure 110s, 120s, creatinine 1.8 on admission. He has been receiving IV Lasix 80 to 8 hours, but he has not been putting out a lot of urine, and creatinine is rising to 2.5. JVP is 15 to 20 centimeter. What is the next step? No peripheral edema, no crackles on exam. So here's the idea. Crackles are very insensitive and non-specific in heart failure. I don't even know why they teach those in medical school for heart failure assessment. Most decompensated heart failure, up to 80%, do not have crackles on exam despite high wedge pressure. And frequently, crackles on exam are not heart failure. They could be lung disease, lung fibrosis, atelectasis, COPD. Crackles are infrequently heard in decompensated heart failure simply because in decompensated chronic heart failure, even when wedge pressure rises, you have a pronounced lymphatic drainage. It's hard to get alveolar edema. It's alveolar edema that causes crackles. So you do hear crackles in really hyperacute heart failure in somebody with acute MI on top of a healthy heart. Patients who did not have time to develop pronounced lymphatic drainage and who develop alveolar pulmonary edema. Peripheral edema in the right setting is quite specific for heart failure, but it's not very sensitive. You need to be about 4 liters overloaded to develop peripheral edema. So in that patient, a lot of internists would see the creatinine rising along with no peripheral edema, no clear pulmonary edema, even on chest X-ray. So the reflex would be that you either need a right heart cath to assess filling pressures, or they would step down on diuretics. I will tell you, this patient doesn't need right heart cath, and you certainly should not step down on diuretics. The JVP alone, which is the most sensitive and specific markers of congestion, tells you need to more aggressively diurese this patient, need higher dose of Lasix, and likely you need a booster for the Lasix, metolazone, chlorothiazide, acetazolamide. And if he continues to not respond to diuretics along with a borderline blood pressure, we need to consider inotropes. Check lactic acid, but even if lactic acid is elevated, it could be what we call the normotensive shock stage C, where the first line of treatment again is optimize your diuretic regimen. Be more aggressive with your diuretic. And the hint to that in this patient is the JVP. I will move on to describe lung ultrasound. The way we perform lung ultrasound, we scan the lung using a probe that we hold vertically between two rib spaces. We hold it vertically, not horizontally. And we use a peripheral curvilinear transducer probe, or we can use an echocardiogram probe and use a low frequency setting to assess significant depth, like a 10 centimeter depth. We typically do it in a supine patient, and we divide each side of the chest in 4 zones, 2 anterior and 2 lateral zones. And we use a deep field of view, typically around 10 centimeters. And keep in mind that the lower lateral zones are close to the diaphragm and to the liver or the spleen, as well as the kidneys posteriorly and the spine. That will be important when we talk about pleural effusions. Normally, what do we see? So we put our probe between the two ribs vertically, and this is what we see. We see the two ribs, and we see a white hyperechoic pleural line between the two ribs, along with curved white lines that are reverberations of that pleural lines and that we call A lines. Those attenuate with depth. The normal lung is filled with air and it cannot be visualized by ultrasound because air is the enemy of ultrasound. However, you see A-line reverberations from the hyperechoic pleural line through that air-filled lung. Beside those A-lines reverberation, another characteristic of the pleural line is that horizontal shimmering motion that we call lung sliding, which corresponds to the sliding and rubbing of the visceral and parietal pleura during respiration. In fact, if you put an M mode and a shallower depth analysis of that pleura, you will see this. You will see reverberation beneath that pleural line that are interrupted and dynamic, the so-called seashore lines, which are kind of similar to the A lines that we see on deeper depth. Those are important. Why? Because lung sliding is lost in pneumothorax. And actually, when you see a point where you move between lung sliding to no lung sliding, that confirms that you have pneumothorax at that point. You also lose lung sliding in other conditions. That's why loss of lung sliding is not specific for pneumothorax. Seeing a lung point transition is specific for pneumothorax, but the loss of lung sliding can be seen in pneumothorax, but it can also be seen in pneumonia and in atelectasis and in COPD, other lung conditions, where the pleura may become more static. Now, most important for us, when we have pulmonary edema, we will have a fluid in the interlobular septa and thickening of that interlobular septa, the so-called B line on chest X-ray. And those B line will be seen by ultrasound as comets or flashlights that are arising from the pleural line, are mobile, and move along with the lung sliding. They are better appreciated on dynamic images than on that static images. You'll see those flashlights moving around, and they reach all the way to the far field. They do not attenuate with depth, unlike A lines. And actually, they erase the A lines. You cannot have B lines with A lines. If you still see A lines, then those are probably not B lines, and you're having artifacts. B lines do not attenuate with depth, reach all the way down, and erase A lines. And they are very mobile, like ants. And to be pathological, you need to see 2 to 3 B line in the same intercostal space in at least 2 lung zones. So you put your probe here, you see 2 to 3 B line, and you need to have it in at least 2 lung zones to be pulmonary edema. Now, when you have it in 1 lung zone, it means there is a fluid in the lungs. It could be, for example, pneumonia. But when you have it in multiple lung zones, it's either cardiogenic pulmonary edema or severe pneumonia with ARDS, non-cardiogenic pulmonary edema. But meaning when you see it in multiple lung zones, it's highly suggestive of some sort of pulmonary edema, whether cardiogenic or ARDS. And this is a very helpful finding because this may precede the overt signs of pulmonary edema on chest X-ray and may accompany the more subtle signs of heart failure on chest X-ray. And you have other pathological findings in heart failure. You may see dark anechoic space at the surface, which is a pleural effusion. The lung itself is air, is normally not visible by ultrasound, but when the lung is seen as a mass similar in echogenicity to the liver, it will be white echogenic lung. This indicates lung consolidation, sometimes with dark air spots of bronchogram. And in the right context, this could be lung consolidation from pulmonary edema. In other contexts, it could be lung consolidation from pneumonia. So in some, cardiogenic pulmonary edema progresses like this by ultrasound. You will have 2 to 3 B lines in 2 lung areas with a small anechoic pleural effusion. Then you progress to more extensive B lines in 4 or more lung areas with a larger effusion. Then you progress to even more extensive B lines along with larger pleural effusion and lung consolidation, which is hepatization of the echogenicity of the lung with air bronchogram. The same progression may be seen in pneumonia with ARDS, bilateral ARDS, except for less extensive pleural effusions in ARDS. This is another illustration of extensive B lines that you can see. Those are the ribs. This is the pleural line with lung sliding here. Then you see extensive flashlights. You have here about 5 B lines in one intercostal space. This is another illustration of those extensive comet-shaped B lines. Again, extensive B lines. Get yourself used to seeing those B lines in intercostal spaces across multiple lung quadrants. This is how the pleural effusion looks in an anterior intercostal space. It's an anechoic or hypoechoic space between the chest wall and the visceral pleura / lung line. It's best seen in the dependent lung area, and often we see it best in that quadrant here, close to the liver, as we see, for example, on this image. So when you scan that area, you will see the liver, you see the diaphragm, you see the pleural effusion, and you see the lung. Frequently, you will see solid lung, which may be in accompanying consolidation in a patient with pulmonary edema, or it could be atelectasis, or it could be pneumonia, a lung that is as echogenic as the liver, a consolidated lung. This is another case here, a pleural effusion, liver, a consolidated lung, either heart failure with lung consolidation and pleural effusion, or pneumonia with parapneumonic effusion. When that pleural effusion is larger than the consolidated lung, then it's likely that you have a pleural effusion and secondary lung atelectasis. Now I want to briefly describe an important finding on lung CT that indicates cardiogenic pulmonary edema. Frequently, patients these days get lung CT for one reason or another. So whenever on lung CT report or images, you see interlobular septal thickening, think cardiogenic pulmonary edema. This finding is highly specific for cardiogenic pulmonary edema. Normally, the lung is split in lobes, and lobes are split in segment. For example, on the right side, you have 3 upper lobe segments, 2 middle lobe segments, and 5 lower lobe segments. 10 segments overall. On the left, you have also 10 segments, 5 in the upper, 5 in the lower lobes. Segments are split into secondary pulmonary lobules, and secondary pulmonary lobules are split into acini or primary pulmonary lobules. There are septa between those secondary pulmonary lobules that are normally not visible by CT scan. They become well demarcated in case of interlobular septal thickening. Smooth interlobular septal thickening is overwhelmingly indicative of cardiogenic pulmonary edema, hydrostatic edema, and is mostly visible in the periphery of the lung, whether in axial or coronal view. This manifests as small, well-delineated polygons at the periphery of the lungs, laterally or medially, top or bottom. And this is an illustration here of that smooth interlobular septal thickening suggestive of pulmonary edema. This here, this line, normally you should not see those lines between, again, those what we call secondary pulmonary lobules. Those are pulmonary lobules. This, those here. You should not see the septa between them. And you typically see those septa at the periphery of the lung. Those here. Normally you should not see those. Those here. You should here. Those. All those are interlobular septal thickening, suggestive of pulmonary edema. Those correspond to the curly B lines on chest X-ray and to the B lines on lung ultrasound. And typically, in that cardiogenic pulmonary edema, beside the interlobular septal thickening, you will see ground glass opacities, as you see here, that mild white veil over some parenchymal area, typically in a mosaic pattern. So you see here ground glass opacity, you don't see it here. So it's in a mosaic pattern, mild white veil, and that ground glass indicates mild interstitial or parenchymal thickening. You typically also see in those patients some degree of pleural effusions. It's hard to have cardiogenic pulmonary edema without some pleural effusion on chest X-ray or on chest CT. So this is smooth interlobular septal thickening is highly indicative of cardiogenic pulmonary edema. Only rarely it may be seen with lymphatic obstruction from lymphangitic carcinomatosis. But even in lymphangitic carcinomatosis, this interlobular septal thickening is usually more nodular and asymmetric. Now, irregular septal thickening that is more nodular than this and thicker than this may be seen in interstitial lung disease and fibrosis, sometimes with a dense, crazy paving pattern, and in extreme cases, honeycomb pattern. But that smooth pattern with mild mosaic is cardiogenic pulmonary edema.